Okay, again, welcome to the Healthy Future lecture series presentation today. And I'm delighted to be introducing today's speaker, Dr. Anna Lowe. Anna is currently Associate Professor of Physical Activity and Population Health in Sheffield Hallam's Advanced Wellbeing Research Centre. And she's a chartered physiotherapist with a special interest and high profile in physical activity and healthy aging. Anna worked in the NHS for many years, and this was followed by policy roles at Public Health England and NHS England. After a very successful spell as programme manager, she has recently been appointed as the director of the National Centre for Sport and Exercise Medicine in Sheffield. And Anna now leads a large number of significant physical activity research projects alongside overseeing Sheffield's physical activity strategy, Move More. I'm really excited to hear more about these projects and the National Centre for Sport and Exercise Medicine in the talk this afternoon. And I'm really pleased to be handing over to Anna for her presentation. Over to you, Anna.
Brilliant. Thank you, John. Thanks for the introduction. And it's lovely to be here with you all today and contribute to the Healthy Futures lecture series. So thank you for having me. Just bear with me while I share my screen. Okay, John, can you see that okay? Yeah, brilliant. So I've got a bit of time with you today to talk about Olympic legacy here in Sheffield, and specifically whether Olympic legacy can drive healthcare transformation. And we're going to spend a bit of time exploring the impact of co-locating NHS services within community leisure centres. As John said, there'll be time for questions and answers afterwards. So please contribute questions as we're going through the session, and I'm very happy to try and answer those later. It's absolutely lovely to see such a range of people on the call, that I can see people from pretty much every stage of my career. So people I went to university with and people I work with currently, and everything in between. And just a quick konnichiwa to our Japanese colleagues who are joining us today. Hello, it's lovely to see you. So I will crack on. So just very briefly, most of you probably live and work in Sheffield or know about Sheffield, but just very briefly, I wanted to pick out a couple of things that are special and different about Sheffield, because they set the context for the work that we've done here. So Sheffield, in case you don't know, is a large city in the north of England. We have a population of about 550,000. Sheffield's known for lots of different things, but two particular things that Sheffield is known for. Firstly, our parks and our green spaces. Approximately a third of the city is within the Peak District National Park, so we have amazing proximity to wilderness and open space and green spaces, and we have beautiful parks threaded right throughout the city. It's a real asset. We're a very green city, and there's a picture on the screen there that shows one of our parks, Parkwood Springs, which is really close to the centre of Sheffield. It's got amazing walking, cycling infrastructure there, and you get these beautiful vistas of Sheffield. So we're known for our green spaces. And we're also known for our stark health inequalities. And this is something that was illustrated really clearly by a piece of work that was done a few years ago by the Fairness Commission in Sheffield. And they mapped the journey that the number 83 bus takes across Sheffield. And what they found is that when the 83 bus starts in the southwest of the city, female life expectancy, to give you an example, is around 86 years. And as the bus moves north and east across the city, you only need to travel a couple of miles and get into areas like Burngreave, and where the female life expectancy is 76.9 years. So you have, within a matter of minutes and a matter of miles, you have a 10-year discrepancy in life expectancy. And that is mirrored today in healthy life expectancy as well. So the amount of time we can expect to live free of the burden of disease and illness. And Currently today, the gap in healthy life expectancy between the most affluent and the least affluent parts of Sheffield is about 20 years. So we know we have these huge discrepancies in inequalities in health within our city. We also know that one of the things that can support people to live well, that can reduce disability and can really help to grow health, is engagement in physical activity. It's a health promoting activity, and it helps prevent and manage a whole range of health conditions, and it helps people to live well. What we know about health is that the things that contribute to whether we are healthy or not are very, very broad. They're not limited to individual factors, so they're not limited to things like your motivation to eat well or your motivation to exercise. There are many wider determinants of health that have a really powerful impact on our health and our aging trajectories. So things like where you were born, your levels of education, your ethnicity, your gender, all have really powerful impact on our health and our ability to age well. And what we tend to see is that in people who have lower life expectancy or lower healthy life expectancy, they tend to be the groups of people who engage less in physical activity as well. So we have this poor health paradox, whereby the people who have the greatest amount to gain from becoming physically active engage the least. So there's this inequality is compounded at that level as well. So I just wanted to show you this data from Sport England's Active Lives survey. This is Yorkshire data, so the region that Sheffield is within. This is Yorkshire data, and it maps the proportion of the population in Yorkshire that are sufficiently active for good health. So that is, they achieve at least 150 minutes of moderate to vigorous physical activity over the course of a week. And they're in light blue at the top. We've then got at the bottom, we've got the proportion of people who are fairly active, and then here in dark blue, we've got the proportion of people who are considered to be inactive. And to meet the criteria for being inactive in this context, you have to fail to accrue 30 minutes of moderate to vigorous physical activity over the course of a week. So to qualify as being inactive, that the levels are really very low. And what you can see in this graph is that across Yorkshire, we haven't really shifted the dial. We haven't really changed anything from 2015-16 to the present day, though the trends in those data are very consistent. And if we quickly just compare that with national data, again, we've got the proportion of people nationally who are sufficiently active, those that are inactive at the bottom, and those that are fairly active in the middle in orange there. And again, you can see just a very consistent pattern in the data that we're not really making a dent in levels of physical inactivity. So if we are committed to changing health inequalities and tackling health inequalities, which is something we are absolutely committed to doing in Sheffield, and if we really accept that physical activity can have a powerful influence on those things, and we want to address that, we reflect the data, we're really not changing things at the moment. So we have to think about working differently and thinking differently. And in Sheffield, we had an amazing opportunity that really catalysed an awful lot of change, and that came in the shape of the 2012 London Olympics. So I'm sure you'll all remember the 2012 London Olympics. Amazing games, the most successful for Team GB since 1908, apparently. We had 65 medals, over 39 different disciplines, and you can see from the picture there's an awful lot of bling on that picture. There were a lot of medals. It was incredibly successful and exciting games. And what's really important about the 2012 Olympic Games is that it's had real legacy in Sheffield. So after the 2012 Olympic Games, we had the opportunity to bid for some Olympic legacy funding. We did that alongside network partners in East Midlands and in London, and each of those centres was successful in gaining £10 million of capital investment into Sheffield. And so this brought a whole range of partners together in Sheffield to really get around the table and think, how can we work differently? How can we think differently? How can we use this £10 million of capital investment to really change health and well-being of the population in Sheffield through physical activity? So what they decided to do at that time with the investment was to invest in communities and to invest in assets within communities, and the funding led to the redevelopment and refurbishing of 3 community leisure centres in Sheffield. So we have Graves Leisure Centre, which many of you will know, and you can see on the screen there. We have Concord, and we have Thorncliffe in the north of the city as well. So these are all community leisure centres. They're all in areas of relative deprivation within the city as well. So with the Olympic Legacy funding, the leisure centres were refurbished and redeveloped, and critically, we integrated state-of-the-art clinical suites into each of the leisure centres. So the leisure centres have everything you'd expect to see in a normal leisure centre. You've got your high-spec gym, you've got lovely pools, but they've also got the centre at the bottom of the picture there. You can see a corridor, and that's the clinical suite up at Graves. So at Graves, we have 21 state-of-the-art clinical rooms. They're light and bright. They're fully compliant with NHS IT requirements, and that they're a brilliant facility and a brilliant resource. So I'm just going to play this video so that you can just give you a snapshot of what we're doing at those centres. Okay, so that's just it shows you how we are integrating NHS appointments within the clinical suites within those community leisure centres, and just to give you a bit more information about how we're doing that and how the mechanics of how it works. So we think that it gives us extended reach into communities. We hear from the patients that come to the centres that they would never have set foot inside a leisure facility or as something they perceive as sporty before, but because they have their NHS appointment there, it gets them across the threshold and it gets them into the appointment. One of the things we're working really hard to try and do is to make sure that by the time people attend for their NHS appointment, they are already primed and they're already expecting to have a conversation about physical activity. So we're exploring ways that we can get information out to them in advance about the centre and about the expectation that physical activity will be discussed and is important. One of the really lovely things, if I use Graves Leisure Centre as an example, is when you set foot inside there, it's a very, very warm, welcoming atmosphere. And what we hear, again, reflected back from patients, is that they had some trepidation about attending a leisure centre, but actually when they went, they see that there are other people with other people that look like them, other people that they can relate to. So that might be people using walking aids, it might be people with reduced mobility, it might be people with various levels of impairment, but it's somewhere that they feel that they belong and feel accepted, and they don't feel like they stick out like a sore thumb. It's really important to us that that's the case and that people feel welcome. We we worked really actively to try and avoid any sort of segregation. So there is a shared coffee space where people who are using the leisure facilities will mix with people who are there for a clinical appointment. When you're waiting for your appointment, you can see into the swimming pool, and you might see that there's a very inclusive aquarobics session going on. You might see people piling out of walking netball and sitting down having a coffee and a laugh. It's a really lovely, friendly, inclusive environment. There were elements of the built design that were really intentional and to try and foster that integration and that inclusiveness. So the shared coffee space and the shared reception area is one of those. The fact that the staircase is front and center when you walk in as well, just to really encourage people and give people a bit of a nudge to be active. There are lifts for people that need them, but the first thing you see is the stairs, and you're encouraged to use them if you can, if you're comfortable to do so. One of the key things that we do is around the conversation, and we work with the healthcare providers that deliver the NHS services to make sure that they have the skills and the capacity and the capability to have really good conversations with patients. And this isn't about ticking a box, and it's not about wagging a finger. This is about starting with a person-centered conversation is of, what does physical activity mean to you? What's important in your life? How can we build it in a meaningful way that's not off-putting and something that would work for you and that you might enjoy. So the healthcare professionals are very skilled, and we hope to work further with them to develop those skills within the clinical services. And then the healthcare providers have a range of options of how, at the end of an episode of care, how they can link people up with other opportunities to maintain the behaviour change and maintain the physical activity afterwards. So they can refer people into the Sheffield Physical Activity Referral Scheme. They can support them to become gym members and to use the leisure centre independently. They can connect them in with social prescribing link workers across the city who will know all the opportunities for activity in a particular locality, or they might just recommend a walking group or a gardening group that they know of that's close to the patient. So there's a real focus on the conversation within the clinical interaction, but then also on connecting people with opportunities to be active afterwards as well. So across the 3 sites, we have over 20 clinical services being developed, that are currently being delivered. So we've got over 20 different services there. So at the 3 sites, at Graves there's 21 clinical rooms, at Thorncliffe there's 6, at Concord there's 9 rooms, and then we have the additional 7 rooms at the Advanced Wellbeing Research Centre as well, which is a sort of extended arm delivery centre as well. So we've got the 20 services there, and collectively across the 3 national centre sites, they deliver over 100,000 appointments annually. So they are, particularly for musculoskeletal conditions, they are really high volume, high delivery delivery centres for the NHS. So in terms of impact, so what does it all mean and what impact has it had? As I mentioned before, we have extended our reach into populations who might not usually entertain the idea of going into a leisure centre. So we think we have extended our reach into different populations and supporting them to be active. We have really good patient feedback. Patients like going to the co-located centres. It's a more often perceived as a more pleasant experience than going to a typical NHS hospital appointment, for example. So we get good feedback about that, and it's not just because of the proximity at Graves to the retail park as well. So we get a range of feedback from patients around why they like it and why it's a enjoyable experience for them, as far as it can be. We get really good feedback from clinicians about why they like being at the co-located centres to deliver their services. They like the light, bright facilities. They like the fact they have space. They like the fact that they're co-located and that they can use the facilities at a reduced cost as well. They like the fact that there's secure bike parking and all of those things. And we know in the current healthcare climate, with the stress that healthcare providers are under and the rates of burnout, that supporting workforce wellbeing and enabling people to be happy and healthy and productive at work is really, really important. So we have also meaningfully increased NHS capacity. So we know estates within Sheffield teaching hospitals are very, very tight. We know there's not enough space for the services to be delivered. So when these sort of 30-ish rooms became available, it enabled them to deliver more services, enabled them to reduce their backlog as well. So we've increased NHS delivery capacity, which is really important. We've also got some very tentative early data that are DNA rates, so our rates of people who do not attend, that's a DNA rate. So this isn't about cancelling appointment, this is about a no-show, that we think our DNA rates are lower than at other sites. So if that's scaled across services, the amount of waste within a system, if people aren't attending appointments, can be really significant. So we think there's potential for greater efficiencies there if we can reduce those do not attend rates. We've increased patient choice, so we've given people non-medicalised options for having their healthcare. So if you consider yourself to be generally well and you are rehabbing from an injury, you might prefer to go to a location that is enabling of physical activity conversations and isn't a sort of medicalised hospital environment. So we've given patient choice, we've given patients more choice about which venue they go to across the city. We've got some really good examples of innovation, and some of this is just really unexpected things that have been the product of corridor conversations between different groups of clinicians. So because we've got quite a mixed bag of clinical services, corridor conversations have led to some really interesting and exciting service innovations and new service developments. So that's been a really nice byproduct that we didn't expect from the co-location model. We've got more people having good conversations with patients about physical activity, and we know that when people have a long-term condition, there is a particular teachable moment when they connect with a healthcare provider, and we think we're able to do that at greater rates, at more scale, to use those teachable moments to change behaviour at scale through the clinical interactions. And we are connecting people into physical activity pathways consistently. So when it's appropriate, the healthcare provider can help connect into a relevant physical activity pathway. And to give you an example, if we look at the Sheffield Physical Activity Referral Scheme, then the biggest referrer into that scheme is one of the large co-location providers. So we know that those referral routes are active and being used. So our aim is to meaningfully embed physical activity into healthcare, and to really develop the 3 co-located sites as absolute exemplars of how you do that. And if we can do that, we will have an impact on individual level physical activity. And if we can support people at scale to become more active, we know that will have a positive benefit on health and enable people to live well, improve health and well-being at population level. So a little bit more on impact. We have collected data and published as we've gone, and we've got ambitions to do a lot more of this. We've collected a lot of qualitative data, we've collected service level data, some of this we've published. So some of the papers on the screen there, it's only a snapshot of the type of things we've been involved in. Some of it relates specifically to the co-located centres. Some of it is more broadly around how you embed physical activity into healthcare, but there is a growing body of evidence that we've contributed to around that integration. We've also written this up as a research excellence framework impact case study last year. So we've compiled all the information and the supporting statements, and that went in as an impact case study. We've had good feedback from that. When these slides are shared later, if you click on the image on the left, it will take you to the impact case study, so you can see that in more detail if you're interested. And if you click on the image on the right, you will go to an accessible write-up of the impact case study that's on the Sheffield Hallam website. That's also got the video that I showed you before, and it's also got links to all the research papers as well. So just to zoom out and think a bit about the co-located centres and how they are assets in Sheffield. So I posed the question of, can Olympic legacy drive healthcare transformation? I think it absolutely can, and I think it has. I think we've gathered data and we've demonstrated impact in Sheffield to show that, and I think there's lots more work that we want to do there. If we're asking the question of, can this solve the problem of physical inactivity in a place, then we have to think much more broadly, and we know that we need to stop thinking about single interventions and initiatives and stop thinking about silver bullets and really think about how these assets sit within our wider system in Sheffield and how they contribute to the long-term change that we want to see. So we know that no single initiative, intervention, organisation, product, programme can shift the dial on physical activity in a place. It is a complex problem. It's often seen as intractable, but we also know that the many assets that we have in our system are all making a small contribution to the bigger change we want to see. So I just wanted to zoom out and talk briefly about how our co-located centres in Sheffield sit within our broader whole systems approach to increasing physical activity in Sheffield and how they contribute to that. So if you look at the cogs here, our 3 co-located centres might be one of those cogs, and the other cogs are the big things that drive whether we're physically active or whether we're not. So that might be how physical activity is delivered through schools. It might be about active travel opportunities. It might be about our places and spaces and the built environment. There are so many factors that influence whether we are active or not, and the co-located centres is just one brilliant asset within that system. So this way of thinking about whole systems approaches to physical activity has really accelerated massively over the last few years in recognition of the lack of progress we were making with single intervention siloed thinking. So in Sheffield, our whole systems approach to increasing physical activity is called Move More. Our aim is to try and create a healthier, happier and more connected city through physical activity. And it's really recognising those broad range of influences on physical activity and the fact that really physical activity is woven through every aspect of civic life. And if we really want to shift the dial on inactivity, we need to connect with people in highways departments and our council and our Chamber for Commerce and Industry and housing associations, as well as the more obvious sort of sport physical activity partners. So I'll just skip through that one. So when we talk about our whole systems approach to physical activity in Sheffield, when we talk Move More Sheffield, we try and explain the benefits of physical activity in terms of those benefits for individuals. So very much around preventing and managing both physical and mental health issues and living well for longer. We talk about benefits for communities as well. So thinking about community cohesion, thinking about the ability of grassroots sport, for example, in diverting people away from crime and reducing antisocial behaviour. We talk about benefits to the economy in terms of healthy, productive, happy workforces, particularly in view of the fact that we're likely to be working for longer. And we also talk about synergies with the decarbonisation agenda and with planetary health as well. If we want people to we want people to be walking and cycling more, and there's obvious sort of multi-solving synergies there with other major agendas at the moment. So we do talk about benefits to the individual, but we also talk much more broadly about how physical activity can really reshape the fabric of Sheffield so that it becomes a healthier, happier, more connected place to live. I mentioned before that physical activity sort of threads through every aspect of civic life. And so when you're trying to work out how you organise a place-based approach to physical activity, it's really difficult and it's really messy because it sort of includes everything and everything's related to everything else. So our approach in Sheffield is broadly under 6 themes. So we have communities at the centre, we have education, which is really looking at everything from early years opportunities to get people to get physical activity normalised and at a family level. right through primary, secondary education, further and higher education as well. Health and social care and those opportunities that I've talked about in relation to the co-located centres. So how can we use those interactions to support people to become more active, and how can we embed physical activity in healthcare? Active travel, I've also mentioned, sport, and that's not just about elite pathways, although they're important. It's very much around grassroots sport and the good that it can do in communities in promoting social connection and mental and physical well-being. And then environments are places and spaces, so how they're designed and delivered and maintained so that they are accessible and really help people to live active lives. So we've got this enormous portfolio of things that are going on in Sheffield that broadly come under the umbrella of physical activity. We nominally sort of organise them under those 6 themes, and the co-located centres are a central asset in this one here, in the health and social care one. So our whole systems approach in Sheffield, we do some really exciting and fun stuff. So we have a Guinness World Record for the highest number of people simultaneously hopscotching, and that was an intervention a few years ago to just give school kids an introduction to physical activity and to look at it through a different lens, to have a bit of fun and to create a bit of a splash. We've had dance-a-thons in the centre of the city. We support inclusive sporting events. We had a colour smash where we got to chuck paint at our mayor and our councillors, who were very, very good sports. And then the final picture there of the kids is a Beat the Street game that we ran a couple of years ago that some of you might remember, where we got 60,000 people engaged in a 6-week physical activity game. So that was 11% of the population of Sheffield actively involved in that game. So we've done some brilliant, really exciting, fun things. We know that no single initiative like that will solve the problem, but it's all about raising the visibility and starting conversations and really celebrating some of the partners and the work that they do in Sheffield. The really important bit of Move More Sheffield is the fact that the whole is greater than the sum of its parts. So in Sheffield, we know that we have an absolute wealth of amazing assets who all contribute to the physical activity agenda. And if you think of them in the black box there as the arrows, and our co-located centres would be arrows in that box as well. So we know that there is a whole load of brilliant work, and the idea with Move More Sheffield, with our whole systems approach, is that we get everybody pulling in the same direction so that we have greater ultimate impact, and so we reduce gaps, we reduce duplication as well, and we really get people working together around a shared vision of a healthier, happier, more connected Sheffield. So my last slide before we move on to questions. So that I asked the question, can Olympic legacy drive healthcare transformation? I've hopefully given you a little snapshot of what happens within the co-located centres. What we want to do is develop those as absolute exemplars of how you do this, and then to scale that up across healthcare systems locally, regionally, nationally, internationally. They're brilliant test beds because of the proximity to healthcare, the proximity between healthcare and the broader physical activity opportunities within the centres, and because of the high volume of the delivery and the scale of people we get through the centres, they're a brilliant testbed opportunity. So I absolutely believe that we can drive, that Olympic legacy can drive healthcare transformation, but if we really, really want to capitalise on the work that the co-located centres can do and the impact that they can have, they have to be nested within an activated, coordinated, connected, coherent approach within a place. And in Sheffield, that's our whole systems approach, Move More. So thank you for giving me the opportunity to share that with you, and I'm very happy to take any questions.
Thanks, Anna. Thanks for a really insightful presentation into a hugely impressive array of work there in Sheffield. In amongst some very complimentary comments in the chat, Anna, there's been some excellent questions posed. So I'm not going to say very much at this stage. I think we'll get straight into those questions.